Well, in case there's anybody on who doesn't know me, my name's Jane Hall, and I'm one of the professors of health economics in Share at UTS and a part of the CRE. I want to formally start the meeting by recognising and acknowledging the traditional owners of the lands on which we're all seated today, many different lands, as we're in very different parts of Australia. Let me just start with the usual housekeeping about these sorts of Zoom meetings. If you would please mute your microphone, that will help with any background noise or other interventions. If you wish to ask a question, please do put something indicate in the chat function or by a raised hand, and there will be the opportunity for questions at the end of Olu's presentation. Before I formally introduce Olu, first of all, a word from our sponsors. This series of webinars is very much about the work we're doing under our NHMRC Centre for Research Excellence funded program, which is about paying for value and improving payment methods, particularly around cancer. So you can hear more about that work either by emailing us, and the email address is on that slide there, by following us on Twitter, or getting in contact with any of the individuals from the Share team at any stage. The webinar is being recorded and it will be available on our website, as indeed our previous webinars are. So thank you for all of that, and it's my pleasure to introduce Olukorede Abiona. Olu has a PhD in economics, and that applied economics means lots of quantitative stuff. So Olu comes to us with those skills from the University of Leicester. He joined Share in 2017. He's been involved in a range of projects, but today he's going to talk to us. You can go to the next slide, Olu. He's going to talk to us about provider behaviour and payment reform, a very important topic because so often we assume that by withdrawing a subsidy for something, the thing will go away. And this is a very important topic to explore in terms of understanding how providers respond to payment reform. So thanks, Olu, and over to you.
Thanks a lot, Jane. I would like to start by saying this paper is co-authored with 5 other UTS members, including Jane herself, Dan, Leo, Miriam, Phil, and Keith. And we're delighted to have an external member in the name of Sarah Neville from APRA as well. So in this paper, in this project that we have now, that we have been doing, that we have been investigating for about 2 years now, we're looking at the unintended impacts of subsidy removal in Australia. And by way of introduction, Medicare provides approximately 5,700 health services that are listed on MBS, which means that there is a fixed rebate per service. So for out of hospital services, patients need to pay the out of pocket, which is the gap between the provider fee that is unregulated and the rebate that is paid by the government. Also, for the in-hospital services, the Medicare rebate is supplemented by private health insurance as well as out-of-pocket costs. In 2010, there are a few regulatory policies, and that's included as well removal of MBS items from this scheme. And in this paper, in this project, we're focusing on the removal of joint injection, which is item 50124. We wanted to investigate the potential unintended or unexpected behavioral changes that this removal brought forth. And This particularly relates to income compensating hypothesis. As we know that when physicians experience loss in income, they definitely will not fold their arms. They will strategically make some behavioral changes. Okay, the joint injection services before 2010 are charged in combination with attendance items by the physicians that are providing this service. And the MPS fee for this item is actually $23.25 per session in the year 2009. From 2010, the joint injection service is no more available for rebates, but physicians that are willing to provide the service are allowed to continue to do so in the new environment. And this simply means that these physicians will lose out on the extra $23.25 that the joint injection service fetches them. And this definitely may lead to pushing of costs to the patients or to the government in terms of rebates, in terms of claims or other claims from other items. We capture this set of physicians by the continued prescription of steroid to patients that are affected by joint injection afterwards. And I will shed more light on that in the next few slides. So this policy constitutes only a very small fraction of the MBS items that are provided by the affected physicians. For example, from the data that we're using, we can see that the composition is just about 2% of all the MBS items that are charged. And in comparison to the consultation items, we can see that the joint injection itself is very low in terms of dollar value. So level B items in year 2009 cost $34.30. Level C items cost $65.20, and level D items cost $95.95. So we can see that relative to even consultation items or attendance items is quite low. So this constitutes a very small shock. But the question remains, will this small shock lead to any behavioral changes? And we want to quantify that change. That is the reason, that's the main reason for this research. The overarching objective of this policy is that the government is trying to make some savings from perceived low value care. And our research question is to quantify the potential unintended consequence of this removal. There is actually literally no paper that has looked at complete removal of subsidy. In the next slide, I would show you a few papers from an abundance of literature that have looked at different policy, healthcare policies across the world, especially in the US and in Australia, but nothing about subsidy removal. So basically, we're making unique contributions, and these contributions are in three folds. The first is to extend knowledge frontiers on physicians' responses or behavioral responses in economics. The second is to use different components of our administrative MBS dataset for deeper insights. And the third would be to provide some evidence that could guide proactive policy designs relating to perspective of impact shock on priority diseases in Australia. Okay, so a few policy tools that have been used across the world include cost sharing, benefit cap restriction, which we have investigated ourselves at UTS here, benefit eligibility regulation, price transparency, and threshold for benefits, amongst others. We have looked at cap restrictions in one of our previous papers, and we have looked at threshold for benefits. These papers actually looked at used robust econometrics analysis across studies, and they are able to interpret their estimate as causal impacts. Some studies also looked at supply side impact of private health insurance experiments. And all this sits within the behavioral hazard theory in economics. So mostly due to asymmetric information that is skewed towards providers or physicians that are not necessarily available to patients or consumers. Most of the evidence emerged from the US, and I'll just speak on just two of these. In the YIP 1998 paper, the basis for this behavioral impact is actually demand inducement hypothesis, because we know that physicians are able to induce demand. And also in the Daphne 2005 paper, there could be upcoding strategy, and upcoding simply means that physicians are able to charge for the highest level item when they're losing income from some aspects of their services. We have two papers from China, and we have our very own paper from Australia as well, which looked at the impact of physician behavioral responses from threshold for eligibility for safety nets. By way of introduction, of course, also on the policy, I will just show you what happened to steroid prescription. Steroids are used with joint injection during joint injection services. So we noticed that before the policy was fairly stable, but afterwards we find that there is a decline in the number of steroids that has been prescribed. And this is the national representative data set. Of course, this has not completely gone away, and that has an implication for our research. It simply means that there are some people that are still providing the joint injection even after the policy took place in 2010. And that's why this policy, this paper project is valid. And to complement what I just showed in the previous slide, we can see as well that arthritis still continues to be treated. So you can see the pattern for knee replacement and admissions in the hospital for also national representative data, that we can see that they still continue to go up without any decline, despite the policy taking off in 2010. And so it simply means that there are still providers for this service despite losing that aspect of income. So we explore the natural experiments that this policy provides to us. And the questions that we're asking is, what is the impact of the removal of this subsidy on the billing practice for GP consultation items? We focus on the three categories, which are the level B, the short consultation, medium consultation, which is level C, and long consultation, which is level D. And also, we go to the other side, which is the payment pattern. How does this policy subsidy removal influence or impact fees that are charged by the physicians, the out-of-pocket cost paid by the patient, and even the benefit claim patterns that the physicians put out to the government. And the supplementary question would be, what is the distribution of the policy impact according to the exposure level of GPs to the income shock? So we know that the income shock is going to be very small in general, but it will be bigger for some GPs compared to other GPs in terms of the number of joint injection services that are provided before the policy took place in 2010. Empirical context. So one MBS item affected by the subsidy removal in 2010, providing a unique regulatory setting at that time, because up until that time, there were no policies that are directly affecting GP MBS services. Now, we know that joint injection services are provided by general practitioners, GPs, and specialists. In this paper, we focus just on the GPs to preserve homogeneous nature of physicians in this category, and that also helps with the trackability of our analysis. Australia GPs have extensive scope to change behavior in terms of response to subsidy reform of this kind due to fee-for-service payment system that we practice here. Can this change lead to billing practice changing as well, especially in relation to consultation item, which is jointly charged with the joint injection before its removal? Secondly, do they respond by adjusting their payment structure in terms of the fee that they charge? And which component of this fee charge changes? Is it the out-of-pocket cost or the benefit payments? So how did we define the treatment and control groups? So we focus on joint injection as the policy item, and we use this to capture the treatment GPs. So we restrict our data sets to GPs that are prescribing steroid drugs pre and post policy. And the reason is because we can only track those who prescribed steroid after the policy took place in 2010. We proxy for joint injection, as I said earlier on, because this is a joint growth with steroid use. So we're able to capture those who still continue to provide the joint injection afterwards. For our control groups, we link our control group to 3 MBS items that are comparable to joint injection, and that's diagnostic biopsy. We use 2 other items as for robustness of our results, but we focus, the main results come from DB, the diagnostic biopsy. Due to the non-mutually exclusive nature of the policy, we have different treatment GPs, because some GPs that provide joint injection also provide diagnostic biopsy. So we have, in some cases, exclusive treatment group where we only exclusively focus on joint injection and not diagnostic biopsy. Of course, we have the alternative one, which would be the interactive treatment group, where the GPs are allowed to charge both for joint injection and diagnostic biopsy. And the third one is the combination of the first 2. So we look at these 3 treatment categories separately to show that our results are not necessarily sensitive to the kind of treatment group that we use. Note that control groups are completely isolated from only just GP services, so they do not interact with the joint injection. They do not interact with joint injection. They only focus on diagnostic biopsy. Our results remain the same, roughly the same across the alternative comparison groups and treatment control classifications. So for this paper, in the analysis, we use 45 and up, which constitutes 267,000 community-based sample of people living in New South Wales. MBS data sets, our focus is on 2008 to 2011. It includes provider unique identifier, specialty group, fee charge, out-of-pocket cost, and benefit payment for each MBS claims. And we also needed the PBS data sets for this steroid in this case, because we make reference to the date of steroid prescription in our analysis. And so in that regard, what we do is that we have to make reference to this, because we use this to capture the timeline for loss in income that is experienced by the physicians. So we used a very rigid time frame, which is same day to the time of steroid prescription, and we use very flexible one, which is 3 day to the time of steroid prescription. We used in this paper a difference in difference method to estimate causal impact, and we also included provider fixed effects, so we can so it can show that it's within provider impact that we're actually estimating, not between providers. So before I go to the results, we have a very small conceptual framework that we designed for this paper. And the summary of this framework is that we're investigating 2 conflicting side motives of each physician and we'll capture that on the average. And for the, so this is the physician utility function, and we have the selfish parameter, which is 1 minus alpha, and the altruistic parameter. So for the selfish parameter, we simply looked at the price of the service provided to the patient minus the cost, which of course signals the profit across all the patients. And when we sum this together, we scale it by the selfish parameter, which is 1 minus alpha, or we can call it profit motive as well. So for the altruistic bits, which is quite interesting, we know that some providers or some physicians are as well, they're kind to the patients in terms of being very careful about the health utility that is derived. And so they measure that alongside the price that each of the patients have to pay. And so when we remove the price the patient has to pay from the utility, from the health utility of each patient, we scale that by the altruistic motive, and we sum this over all the patients that are attended to by the physician and scale that by the altruistic motive. And so we combine these 2 together to show that we can indeed have more altruistic or less altruistic physicians, and that will definitely play a role in the parameter, in the magnitude of the parameters which should scale, which should sum up to 1 in this analysis. The data requirements for the 2 components of the provider utility is the fees charged by the physician or by the provider, and the government benefit, which is representing the selfish responsive hypothesis. Whereas when we look at the out-of-pocket cost that is paid by each patient, of course, that should signal some average altruistic responsive behavior of physicians as well. And going forward from that, we hypothesize some predictions, and we believe that to satisfy the income compensating hypothesis, physicians may want to change their billing from short to long-term consultation items. Secondly, they may want to show an increase in out-of-pocket costs for non-altruistic GPs. And indeed, heterogeneous physicians will definitely, heterogeneity of physicians will definitely play a role in the out-of-pocket cost or even the fees that are charged per service across board. Our identification design is showcased in this table. We used pre-policy period 2 years, 2008 and 9, and the post-policy period 2010 and 11. So our treatment GPs, as I described earlier on, are those related to the joint injection with steroid prescription, and we have 3 categories for those, and the control GPs are for the diagnostic biopsy. So we have MBS claims pre-policy. This includes the joint injection. Post-policy excludes the joint injection for the treatment group, and we have the treatment differential. For the control group, we have the MBS claims pre and post-policy, and we have the control differential. Of course, this excludes, in both cases, the joint injection. And we have our treatment effect as diff in diff. So our outcome variable varies across billing practice and payment patterns. Our treatment effect is the third diff in diff from this regression specification. We include patient and household level characteristics that we have from our 45 and up data set, and also include physician level indicators as well. Just to note that our error terms are clustered at the postcode level to capture spatial correlation of physician charging behaviors. And we have our first preliminary results on table 1. So on the left plane, we have our billing practices, and on the right plane, we have our payments from the physicians. So we also have 2 panels for our results. The panel A captures the 3-day MBS claims from the date of steroid prescription, while panel B is same day. Like I said, the same day is the rigid time frame, which is looking at responsive behavior on the same day that the loss took place, whereas for the panel A, it's a generous one, which is looking at 3 days from that. So focusing on panel A, we do not, so for short consultation item, which is level B item, it simply means that we do not find any impacts of the policy on short consultation items, or invariably level B, charging for level B. When we move to the medium consultation item, we can say that our result is significant at 5%, and it simply shows that there is 1.14 percentage points increase in the likelihood to charge for the level C items after the policy took place for the treatment GPs compared to the control GPs. Then for the long consultation, our result is much smaller compared to the medium consultation, which is because level D are usually very small in terms of composition to level C. But we estimate a statistically significant impact, and that is just a 0.42 percentage point increase in likelihood to charge for level D items amongst all other items for the treatment GPs compared to the control GPs. Okay, so when we move to the payment section, We also did not estimate any impact for our out-of-pocket costs variable. However, for the fee charged by the providers, we can see that there is indeed a statistically significant impact, which is around 3.6% increase in the fees charged for the treatment GPs after the policy compared to the pre-policy period compared to the control group. And the same, very similar results when we look at the benefits paid, also statistically significant. Of course, when we compare these two together, they're much more bigger than the out-of-pocket costs. For the same day claims, of course, we have reduced number of MBS claims in terms of observations. We have now around 88,000 observations compared to 155 in the 3 days. But we can still see very similar patterns. So for example, level D items, of course, now increases by 0.8 percentage points compared to the pre-policy period and compared to the control group, and significant at 5%. And we can see that our provider fee has increased by 7% as well, and which is very similar to the magnitude of impact estimated for the benefit paid. So in very simplistic terms, what this result means is that on the average, one additional level B item for the treatment GPs relative to control group for 100 MBS items provided after the policy. And another billing practice result that we have is that on the average, we have 4 additional level C from 1,000 MBS items provided after the policy. Whereas for the payment estimates, it simply means that on the average, we have 4% increase in fees and benefits for treatment GPs relative to the control GPs after the policy. These results, like I said earlier on, are within provider fixed, estimated with provider fixed effect, signaling that we have within providers. So it's also have the tone of within provider. So it's relative to what the providers were doing prior to the policy, and not between providers. To estimate our heterogeneous results, we compared 4 different quartiles of the treatment and control groups. And what we did here is that we looked at GPs that are more exposed in terms of composition of their services, in terms of the fraction that of services that they provided before the fraction of joint injection services provided before the policy took place in 2010. So we focus on just 2009 in this case. And we distributed this into 4 different quartiles, which for quartile 4 being the highest composition, while quartile 1 is the least composition. We did the same thing for the control GPs, where we're focusing on just diagnostic biopsy for the distribution of quartiles. And in this case, we compare quartile GPs, GPs to quartile GPs for the treatment and the control groups. And we can see, so we're focusing here just on level C, level D item in the billing practice result, where we do not find any statistically significant result, but we can see that our estimate increases with quartiles as well, which simply means that this has increased. The quartile for those who are more exposed have more responsive impacts in terms of changes to their billing patterns, but no statistical precision. Whereas when we look at provider fee result, we can see statistical precision for the quartile 4 segment, which is actually much bigger than the baseline result that we reported earlier on. So our baseline result is just around 7%, whereas our results in this case is actually 16%, more than twice the estimated impact for the baseline results. And when we go to the benefit paid, we find similar pattern with what we find in provider fee results, but a little bit not as big as what we have there, but it's still almost twice the baseline result that we estimated. And this simply suggests that the results are actually driven by those who are exposed more to the policy shock compared to those who are exposed less. So just to check that nothing was going on prior to the introduction of the policy, we tried a placebo test, and we focused on 2005-6 and 7-8 as placebo pre-policy and post-policy. And in this case, we also used the 3-day category and the 1-day, sorry, we used the 3-day category in both cases for bundling of our results and use of MBS items. And we can see that our estimates do not provide any statistically significant result across all the estimates that we present in this case. And we can see that as they are actually very smaller in terms of the magnitude as well compared to the estimated results in the baseline tables. So the summary of our findings is that we can see that there are direct price mechanisms, and that we estimate from the increase in average fee and benefit for the remainder items. So there is a 4% increase as a result of the policy. There are also greater impacts of GPs that are relatively more exposed to the policy when we looked at the provider fee and benefit claims. We do not, however, estimate any impact for the out-of-pocket costs. And the indirect mechanisms is, of course, from the billing practices, and that in that case, we show that we have 1.4 and 0.4 percentage points increase in the likelihood to bill for level C and level D GP attendances. Roughly the same results using alternative control groups that I highlighted earlier on, and different comparison items. So one implication of our result from the direct price mechanism is that we may say that it seems that the physicians are actually more altruistic in terms of the out-of-pocket cost, but there are also competing selfish motives. So they just the result just shows both cases that there can be both altruistic and selfish GP responses in response to removal of subsidy. And what are the policy implications of this results? We show that providers do capitalize on loopholes of regulatory framework, and we attribute that to the market power that enable physicians to exert price or fee control. Our findings have broader implications on current or previous policy initiatives, which includes MBS freeze, Medicare review, price transparency. In essence, there is greater need for policy design that takes into consideration potential provider behavioral responses. Further, we believe that fee-for-service payment structure is creating important barriers to achieve efficient healthcare delivery in Australia. And that is also causing unintended impacts of, that is true unintended impacts of payment reforms, which may affect also patient and welfare outcomes. So in general, our CRE project, we're trying to investigate the effectiveness of value-based systems, such as bundling of the payment structure, and the result that we provide may provide some useful insights into how we tackle this problem altogether. We have some further research items that we have that we intend to accomplish in the next few weeks or months. The project aims to explore alternative empirical models which should strengthen the policy interpretation of our results. And one of these is that we want to bundle the services for each provider from 1-day or 3-day timelines. And what we aim to do is that we hope that we will be able to ask directly the research question that relates to null hypothesis, being change in average fee being equal to a reduction of $23.25, which is the price per session of the subsidy before it was removed, and the alternative hypothesis of the average fee being greater than this reduction. And the new research design will support evidence on structure responsive behavioral responses. We also hope that at some point we would have access to even national representative data sets that is beyond New South Wales, as we know that 45 and up has that limitation, and provide representative volume of services for our research. So we acknowledge funding from CRE, NHMRC CRE grant number 1171749. And we also acknowledge our data custodians for this research, which is SACS Institute. And also acknowledge Services Australia for providing the MBS and the PBS data sets. Thank you very much for joining us this afternoon. And I look forward to receiving feedback and comments on this paper. Thank you.
Thank you, Olu. And I think for me, there are two things that come out of this presentation. And one is how challenging it is to get those robust estimates that really we need quite complex research designs to have confidence in the sorts of results that you've been able to show us this afternoon. I think that was illustrated very well. The other, I think, is that the health system is a very complex system of moving parts, and that if you push it in one part, something quite unintended might happen in another part. And I think this illustrates that very well. I'd like to open that for comments and questions. And again, perhaps if you stop screen sharing for a moment, I can see, I'll be able to see a few more people. But if you could indicate in the chat or raise your hand, or by all means just interrupt, and I'll do my best to moderate the discussion. But any comments or questions for Olu? Perhaps
we've got Bahare.
Bahare, sorry, thank you. You may need to shout at me. Hello, please, over to you.
Hello, hi Jane, and thanks, Giz. Thanks for giving the opportunity. Although that was a great presentation, thank you. I really enjoyed your presentation. One comment, or perhaps a question from my end: how comfortable or confident we think that we can measure a patient's behavior in this study? And because I suspect part of this, it might come from patients demanding for these types of procedures. And I guess part of that could be related to, for example, the level of the health literacy that our patient they have, or potentially related to some of the factors that related to the suburbs, for example, like the access to other services like physiotherapy or like things like that. Because we're basically looking at the behavior of the providers, but we're not looking at the behavior of the people that they're demanding this service. And I think for me, it's always a challenge, because and might be that out-of-pocket cost might be a way that we can measure it. Because, for example, if we say there's this much amount that patients, they have to pay to get this service, how much they might actually think twice when they go into the GPs and they're asking for such service. Thank you.
Oh, thanks a lot. Yes, so yes, we do acknowledge that there could be an interaction between provider behavior and patient behavior. And so one way, like you said earlier on, is that we could maybe signal that throughout of pocket cost. But one thing we're also trying to do now is to look at even the possibility for heterogeneous impact across patient level of socioeconomic group. So this way, for example, if we distribute our results for low income household and high income household, or rich and poor household, we could even tease out the results more. Because, for example, if we find that the results are driven by just the rich segment of the patient, it simply suggests that the physician seems to be only focusing on getting back the, trying to compensate for the lost income from the rich household and not from the poor household. So we do know, we acknowledge this, and we definitely will take this further in our further research. But I believe my teammates will be able to make some more additional comments as well.
Sure. So good, thanks, Fahara, good question. So I think the focus of this, of the bulk of Olu's presentation is on the GPs who actually do continue on to provide joint injections. But of course, the story that precedes that is the GPs who no longer provide the joint injections. And then I think that's a real, pardon the pun in this paper, that's a real joint decision between patient and provider. Now, conditional on doctors still providing this, that's where I do think that we are observing some provider behaviour rather than patient behaviour, because after all, I don't think patient really has much say over whether they're going to be charged a level B or a level C or a level D consultation, nor around the benefits or the fees. But I think your question goes to what sort of precedes this analysis, which is why are we seeing the decline in joint injections? And that is a patient and provider decision.
Thank you.
Yes, thank you. I think a very interesting point, and one that we'll certainly be pursuing. Leslie, I think I saw your hand up.
Yes.
And hello, how nice to see you.
I'm a bit of an interloper, but it was very interesting and ties in with my interests and some work that I did a long time ago, where we asked doctors in Western Sydney, in the area around Mount Druitt, how they became aware of their patient's financial situation and what they did in response to that. And we were particularly asking about prescriptions. And obviously, you know, that's an area, I think, where perhaps your more altruistic doctors are working, and they need to be so because their patient population is on average not particularly well off. And I just wondered if you'd looked at those sorts of divisions between, say, Mount Druitt and the eastern suburbs. You could do it on a PHN basis, I guess, even, to see whether or not your average that you presented in your papers plays out differently geographically, i.e. socioeconomically.
Yeah, good question. Thanks, Leslie. Olu, would you like to start on that?
Oh, yes, thank you so much. So yes, that is one of the further research that we intend to do. So we will be looking at potential interaction across the different socioeconomic groups of patients, and we could use a variety of indicators for that. We could use the postcode. We could use the socioeconomic indicators such as having access to concession card and stuff like that, to see if the results differ from wealthy to less wealthy households. Thank you very much. I'll check out your paper as well to see if I can. Yeah,
and I think what the results already show is that heterogeneity, with some people raising their fees and others not apparently doing so. So that could well be the underlying cause, that socioeconomic distribution. So thanks for that. Other comments, questions? I think perhaps the obvious corollary, which we haven't really given much thought to yet, and perhaps flows on from Bahare's comment, is what happens to the patients. So these were patients who were getting joint injections. We can see the doctor's behaviour, but it will be interesting to know what happened to them also, though I don't think from the data we've got now we can really tell whether they think they're better off or not as a result. But I think, like so many good pieces of research, this opens up an awful lot of questions that are worth further investigation. Any other comments or questions? Then I think if we were together, we would all be applauding now. Olu, thank you very much for a very good presentation. I think it's sparked a lot of interest, and I'll hand over to Keith for the final message.
Which is just to announce that the next seminar will be hosted by your moderator, by Distinguished Professor Jane Hall, next on the 13th of May, which is a Thursday, from 11 to 12. If you get out your phones right now and scan that square, you'll be able to register straight away. and it'll pop up in your diary with a Zoom link. We are the University of Technology. I'm proud to say that hopefully this will all work. And also just to alert everyone that our website for the CRE is now up and running. You've got the address there, payingforvalue.org.au. And now going way beyond my own comfort zone, which is to let you know that Paying for Value Twitter account is open. And please follow, despite the fact that neither the CIA or CIB are following this, because we don't know how to. And I speak on behalf of Jane here.